How accurate are IGRA tests for TB infection? Have you ever wondered how accurate the tests for tuberculosis infection really are? Let's dive into the world of Interferon-gamma releases assays, or IGRAs, which are blood tests designed to detect infection with the bacteria that cause tuberculosis. These tests measure the immune system's response to specific TB antigens. While they are mainly used to identify latent TB infection, they can also assist in diagnosing active TB disease. When we talk about accuracy, we look at two main factors: sensitivity and specificity. Sensitivity refers to how well a test can identify those with TB infection. IGRAs have moderate to good sensitivity, ranging from about 64 to 92%, depending on the test and the patient population. For instance, the QuantiFERON-TB Gold test shows sensitivity around 78 to 80% in individuals who are not living with HIV. However, this sensitivity drops to around 65% in those living with HIV. On the other hand, the T-SPOT.TB test can have sensitivity as high as 92% in some studies. Now, let's discuss specificity, which is the test's ability to correctly identify those without TB infection. IGRAs generally boast higher specificity than the traditional tuberculin skin test, often exceeding 85 to 98%. This is largely because the antigens used in IGRAs are not found in strains of the BCG vaccine or most non-tuberculous mycobacteria. This reduces the chances of false positives that can occur due to prior BCG vaccination or exposure to environmental mycobacteria. However, specificity can vary based on the population and the TB burden in a region. In areas with a high prevalence of TB, specificity may be lower due to a higher rate of latent infections. When comparing IGRAs to the tuberculin skin test, IGRAs generally have similar or slightly better sensitivity and significantly higher specificity, especially in individuals who have received the BCG vaccine. This makes IGRAs a preferred choice in populations where prior BCG vaccination complicates the interpretation of skin tests. However, it is important to note that both tests have limitations. Neither test can reliably predict who will progress from latent infection to active disease. The World Health Organization and the Centers for Disease Control and Prevention recommend IGRAs as alternatives to the skin test for screening latent TB infection, particularly in low TB burden countries and among populations with BCG vaccination. For diagnosing active TB, IGRAs cannot be relied upon alone due to their moderate sensitivity and specificity. Microbiological confirmation remains essential. In individuals living with HIV, the sensitivity of IGRAs decreases, meaning that a negative result does not rule out TB infection or disease. In practical terms, IGRAs are valuable tools for screening TB infection, especially when BCG vaccination complicates the interpretation of skin tests. They help reduce unnecessary preventive treatment by improving specificity. A negative IGRA result in low-risk individuals can help exclude latent TB infection, while positive results should be interpreted alongside clinical risk factors and exposure history. In summary, IGRAs provide good specificity and moderate sensitivity for detecting TB infection, making them useful screening tools in certain populations. However, their limitations in diagnosing active TB disease and in immunocompromised individuals mean that healthcare providers should integrate IGRA results with clinical judgment and other diagnostic methods. Always consult with a healthcare professional for personalized medical advice.